Good evening, friends. Today we are going to discuss opportunistic infections. Let me start by telling you some basic things. There are 3 things you need to keep in mind. Remember this sentence. Hi, NT, can mucor, as per, history. Hi, points toward, HIV. HIV is a common secondary cause of opportunistic infection. N stands for neutrophils defect. T points toward T-cell defect. Both defects are the main primary immunodeficiency causes of opportunistic infections.
Remember, T-cell defect may not exist alone. T-cell and B-cell are close friends since birth.
And now, let's move to expected unusual organisms which are fungal in nature. CAN stands for Candida. Mucor for mucormycosis. Asper for aspergillosis. And finally, hist for histoplasmosis. Last thing I need to say before I disappear. In case of neutrophils defect, expect skin abscess in addition to opportunistic infection. If you find viral infection associated with fungal infections, think of T-cell defect more than neutrophils defect. If opportunistic infection is associated with dysmorphic features, think to George. Now, we'll discuss diseases that lead to opportunistic infections. I will disappear. See you.
Severe combined immunodeficiency.
Severe combined immunodeficiency is a clear example of both humoral and cellular immunodeficiency, due to defects in both B and T cells, secondary to adenosine deaminase deficiency. So, we need to expect lack of immunoglobulins in addition to lymphopenia. Based on this fact and with reference to first video, we have to expect recurrent sinopulmonary infections with encapsulated bacteria, in addition to recurrent gastrointestinal infections due to B-cell defect. Also, we should expect both sinopulmonary and gastrointestinal infections, but due to different criminals, which are fungal and or viral organisms, for example rotavirus and adenovirus. Mixture of all that organisms often lead to recurrent, life-threatening infections at a mean age of 6 to 7 months. Severe recurrent infections also may lead to failure to thrive. Males are affected more than females, because X-linked severe combined immunodeficiency is the most common form. All the remaining forms are autosomal recessive. Skin rash may occur in case of severe combined immunodeficiency, either due to viral infection or as macular rash that is indicative of maternal T-cell engraftment or Omen syndrome. Maternal-fetal engraftment. Patients with severe combined immunodeficiency lack functional T cells and cannot reject foreign lymphocytes. Maternal T lymphocytes that have crossed the placenta engraft in the infant, mediating a graft versus host process. Commonly present is morbilliform erythroderma, or papular dermatitis. A similar condition may occur with viable donor lymphocytes acquired from non-irradiated red blood cell transfusion. Omen syndrome is exaggerated inflammatory response caused by emergence of oligoclonal T-cell populations. It is often autoreactive in nature. It is manifested by generalized erythroderma with thickened, leathery skin, alopecia, loss of eyebrows and eyelashes. Gastrointestinal-wise, patient may suffer from chronic diarrhea, protein loss leading to generalized edema. Lymphadenopathy and hepatosplenomegaly may exist.
Omen syndrome may have lymphocytosis rather than lymphopenia, because of clonal T-cell expansion. Therefore, a normal absolute leukocyte count does not exclude severe combined immunodeficiency.
Investigation-wise, in case of severe combined immunodeficiency, lymphopenia is the single most important laboratory test during the initial evaluation. However, A minority of patients, about 20%, may have a normal absolute lymphocyte count. Chest X-ray may reveal, absent thymic shadow, signs of interstitial pneumonitis and hyperinflation. Of course, as we expect agamaglobulinemia to be part of the problem, we should expect low IgG, IgA and IgM, but also note that IgG level may reflect residual maternal IgG. It is wise to rule out HIV infection first due to similarity of clinical picture. Lymphocyte subsets and red cell adenosine deaminase levels and metabolites should be asked for. Genetic testing may be considered. Management-wise, we need to ask for protective isolation and strict hand-washing measures to protect the patient as he cannot resist any organism. Avoid breastfeeding if mother is CMV positive. CMV negative and irradiated blood products are mandatory measures. Supportive plan is important, in terms of nutrition, skin care, and genetic counseling for family. Antimicrobial prophylaxis, for example cotrimoxazole for prevention of PCP, acyclovir as antiviral prophylaxis. Itraconazole/fluconazole as antifungal prophylaxis. Immunoglobulin replacement may be needed. Exogenous enzyme replacement using bovine adenosine deaminase conjugated to polyethylene glycol provides detoxification and stabilizes the condition while awaiting hematopoietic stem cell transplantation. Hematopoietic stem cell transplant is the only curative treatment option, with best results if genotypically matched donor. Gene therapy has been used to treat X-linked form.
Let me remind you with a couple of things. Remember that we mentioned the neutrophiles defect may lead to opportunistic infection. Common variable immunodeficiency that we discussed with cynopulmonary infection and also a possible cause especially when T-cell is affected. So please review cynopulmonary infection videos number 2, 3 and 4.
Purine nucleoside phosphorylase deficiency. Purine nucleoside phosphorylase deficiency will lead to similar picture as severe combined immunodeficiency, but with some differences. First, it is autosomal recessive inheritance, not X-linked. Second difference is that it is presented with neurological manifestations, for example spasticity, global developmental delay, and autoimmune phenomena in the form of autoimmune hemolytic anemia and immune thrombocytopenia. Of course, all of that in addition to combined immunodeficiency picture. Hematopoietic stem cell transplant offers the only cure, but its effect on correcting or preventing further neurological deterioration is controversial. DeGeorge syndrome. DeGeorge syndrome is a developmental defects of the fourth bronchial arch and the third and fourth pharyngeal pouches caused by monosomic deletion of chromosome 22q11.2.
DeGeorge means hypoplastic parathyroid gland and hypoplastic thymus.
Velopharyngeal insufficiency and cleft palate may lead to feeding difficulties and speech problems. Cardiac defects in the form of aortic arch and canotruncal anomalies such as truncus arteriosus, tetralogy of Fallot, interrupted aortic arch and aberrant right subclavian artery may be associated. Increased incidence of autoimmunity in older children, for example immune cytopenia, arthritis, endocrinopathies caused by impaired central tolerance and generation of regulatory T cells. The most common presentation leading to diagnosis is congenital cardiac malformation. Diagnosis is confirmed by the detection of 22q11.2 deletion by fluorescent in situ hybridization (FISH). Patients with opportunistic infections and lymphopenia should be investigated for HIV and severe combined immunodeficiency too. Management-wise, infants with DeGeorge syndrome should be treated the way as severe combined immunodeficiency disease. Thymus transplantation shows promise in patients with complete DeGeorge anomaly. Multidisciplinary inputs from cardiac, respiratory, immunology, general pediatric, speech and language, clinical and education psychology teams will be needed.
Chronic mucocutaneous candidiasis.
Chronic mucocutaneous candidiasis presents in childhood with extensive candida infections of the skin, nails and mucous membranes. It is related to defects of dendritic cells or impaired Th1 and Th17 immune response. Genetic basis of most cases is unknown. Chronic mucocutaneous candidiasis may be associated with autoimmune endocrinopathies, for example hypoparathyroidism and Addison disease in the entity called autoimmune polyendocrinopathy, candidiasis and ectodermal dysplasia (APECED), which is caused by autoimmune regulator AIRE gene mutation.
Defects of the interleukin-12 interferon gamma axis.
Defects of the interleukin-12 interferon gamma axis. Intracellular pathogens taken up by macrophages or dendritic cells trigger production of interleukin-12, which binds to interleukin-12 receptor on T cells and NK cells to induce interferon-gamma secretion. And, in turn, activate phagocytic-mediated killing through release of tumor necrosis factor. Defects of the interleukin-12 interferon gamma axis lead to increased susceptibility to intracellular organisms such as Mycobacterium and Salmonella species. 8 molecular defects have been discovered. The more commonly described forms are defects of interleukin-12 receptor beta-1, interferon gamma receptor 1 and interleukin-12p40. Infants may present with disseminated BCG and typical mycobacterial infections, and they are usually unable to form granulomas. Treatment includes antimicrobials and recombinant interferon gamma. Successful hematopoietic stem cell transplants has been reported in patients with severe disease.